It's the PainExam Podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the PainExam newsletter at PainExam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the PainExam app with a premium subscription or access for free with a CME subscription at PainExam.com. And now, without further ado, here's your host, Dr. Rosenblum.
Welcome back. Happy you guys could join us for the podcast today. A lot of exciting things coming up. We have Aspen this summer. I've been working on my international ultrasound courses, so we have a whole slew of courses coming up abroad, especially in Costa Rica. I know a lot of you guys have always wanted to go there, and why not make your trip to Costa Rica also a business expense and a medical education expense, and join me down there where we do a condensed ultrasound course for a couple hours, and you could spend the rest of the day in the sun, surfing, or enjoying nature. If you're interested, go to nrappain.org. We have the ultrasound calendar there. Also, we're doing IV ultrasound training, as well as we have Pain Week coming up in September, LAPS coming up in June in Brazil, and of course, as I mentioned, Miami. If you're looking to study for the boards, go to nrappain.org or just type in PainExam.com. Anyway, let's get started. Today we're going to discuss and compare steroids that are used for epidural injections or other injections for pain and contrast agents. For the pain boards, this is a simple framework, and this will help you ace any of the questions they ask you, as well as make clinical decisions in practice to ensure your patient's safety and that your injections will be therapeutic and helpful. Corticosteroids are primarily therapeutic agents. Contrast agents are primarily diagnostic and safety tools. They ensure that we're not performing any intravascular injections. Steroids reduce inflammation. They don't really promote healing. They work by reducing inflammation and pain, and hopefully the body heals itself. Contrast confirms where your needle is, or at least where the medication will spread. The idea of giving contrast is to make sure that you're not in a blood vessel or in the intrathecal space, and this is to avoid a catastrophic occurrence or injury to the patient. So let's start with the corticosteroids. The corticosteroids most commonly used in pain management include methylprednisolone, triamcinolone, dexamethasone, and betamethasone. The most important distinction on the boards and in real life between these steroids really is particulate versus non-particulate. Dexamethasone is non-particulate, whereas triamcinolone and methylprednisolone are particulate steroids. Betamethasone, is a formulation dependent. Some preparations contain particulates, and some of them of betamethasone acetate combined with soluble betamethasone sodium phosphate, so it can vary. Well, why does this matter? This matters because particulate steroids can aggregate. If there's an accidental injection into an artery during a transforaminal injection, this can cause an embolic phenomenon and cause infarction of the spinal cord or brain. This is why dexamethasone is generally favored for cervical transforaminal epidural steroid injections and often used for initial lumbar transforaminal injections. The FDA has warned that epidural corticosteroid injections can rarely cause serious neurologic injuries, including stroke, paralysis, vision loss, and even death. Epidural steroid use is also off-label, and this is seen from the Anesthesia Patient Safety Foundation. Now let's compare the steroids and see what the differences are between these drugs. Dexamethasone is non-particulate, as I mentioned above. It is water-soluble. It has a very strong safety advantage for transforaminal injections. It has less embolic risk because it does not form large particles. Its anti-inflammatory duration may be shorter than the other particulate steroids, but its safety profile is better and makes it more attractive in high-risk procedures in patients or territories such as the foramen, where there's blood vessels that may feed the spinal cord. Triamcinolone is a particulate, and it's commonly used in epidurals, facets, sacroiliac joint injections, and peripheral joint injection. It tends to have a longer local depot activity, particularly because it's a particulate and carries embolic risk if it's injected intraarterially. Methylprednisolone also has particulates. It has historically been used in epidural steroid injections and joint injections, but is generally avoided in high-risk transforaminals, or especially the cervical spine, because of the particle-related safety issues. Betamethasone can be confusing on the boards. Betamethasone sodium phosphate is soluble, while betamethasone acetate is particulate. Commercial preparations may vary. They may contain both, so you must know the formulation before you're injecting. So board pearls, as you can imagine, non-particulates are really just dexamethasone mainly. Particulates equals triamcinolone, methylprednisolone, and usually or often betamethasone acetate. Steroid side effects, well, there's the local, systemic, endocrine, metabolic, and neurologic categories when it comes to classifying the side effects. Local side effects include post-injection flare, soft tissue atrophy, skin depigmentation, tendon weakening, and infection. Systemic effects of corticosteroids include facial flushing, insomnia, mood changes, fluid retention, hypertension, immune suppression. Endocrine effects include adrenal suppression. Metabolic effects include transient hyperglycemia, which is especially important in diabetic patients. Neurologic complications are catastrophic events, and they are rare, thankfully, but they are relevant for the boards and your practice. So spinal cord infarction, brainstem infarction, seizures, paralysis, and death. These are the most associated with inadvertent intravascular injection, especially with the particulate corticosteroids in the transforaminal space. Now let's move to contrast agents. In pain medicine, contrast is used to confirm needle placement and to give you an idea as to how the medication will spread in the epidural space. It can detect intravascular uptake as well as intrathecal injections and improve the safety profile of these injections. The most common contrast agents are iodinated contrast agents. The examples that we typically hear of are iohexol, most commonly known as Omnipaque, iopamidol, known as Isovue, or ioxadenol, which is Visapaque, and that's also known as Ultravist, the iopromide, Omnipaque is iohexol, or a non-ionic, low osmolar iodinated contrast agent. It's widely used in fluoroscopic pain procedures. Certain concentrations are approved for intrathecal use. It's used in myelography, but does not mean that every concentration or every contrast agent is safe to use intrathecally. The label specifically includes intrathecal indications for selected Omnipaque formulations that are FDA. Check out the FDA access data for that. Isovue, or iopamidol, is an anionic and low osmolar and commonly used. It's commonly used in fluoroscopic procedures. Visapaque, or iodixanol, is non-ionic and isoosmolar. It may be considered in some patients at higher renal risk, though procedural context matters. Ultravist and iopromide is another non-ionic low osmolar iodine agent used in radiographic imaging. Contrast side effects include nausea, warmth, flushing, headache, dizziness, pruritus, urticaria, bronchospasm, anaphylactoid reactions, and rarely severe hypersensitivity reactions. Renal risk is primarily concerned with larger intravascular doses, especially in patients with chronic kidney disease, diabetes, dehydration, or concurrent nephrotoxins. Board pearls for contrast allergy is often mislabeled. Shellfish allergy is not the same as iodinated contrast allergy. Keep that in mind. Another board pearl is that in fluoroscopy, epidural injections, contrast should be used before injecting steroid to confirm epidural spread and to exclude vascular or intrathecal placement. So now we can discuss the gadolinium-based contrast agents. Gadolinium is sometimes considered when patients report iodinated contrast allergy, but this is dangerous. Gadolinium-based contrast agents are not FDA approved for epidural or intrathecal use. ASRA specifically warned the inadvertent intrathecal gadolinium can cause severe neurotoxicity, encephalopathy, seizures, and death. You can look that up at ASRA's website. During iodinated contrast shortage guidance, ASRA stated that gadolinium-based contrast agents should not be used for spine-related procedures such as interlaminar epidurals or transforaminal epidural steroid injections when iodinated contrast is unavailable. Gadolinium may be considered only with caution in selected non-neuraxial procedures. Intrathecal gadolinium toxicity is a must-know for the boards for safety. As I mentioned, it can be quite damaging and harmful to the patient. Patients may also report headaches, confusion, altered mental status, seizures, respiratory distress, arachnoiditis-like symptoms, and death. So if a patient has a true severe iodinated contrast allergy, options include allergy clarification, pre-medication protocols when appropriate, use of ultrasound guidance for selective non-neuraxial injections, or postponing elective procedures rather than substituting. And my advice would be, if you're doing a cervical spine injection, use ultrasound. You may not know your level unless you use an x-ray as well, but you can see the nerve roots as they exit the spine. I do this all the time, and it works really well. 90% of patients will never need a regular epidural if you do this properly. I don't do cervical transforaminal injections. I typically do extraforaminal injections. It's safer. But for the boards, the bread and butter, cervical transforaminal epidural steroid injections, if you're going to do it, use a non-particulate steroid. Once again, dexamethasone is safest. Use live fluoroscopy or digital subtraction angiography when available. I'd say and, not or. For lumbar interlaminar epidural particulate steroids, they may be used by some clinicians, but safety concerns, and you should use the contrast agents. Of course, aspirate before you inject. For facet and SI joint, the embolic risk is much lower, so you could consider particulate steroids, but there's still systemic side effects. And worry about diabetics with their blood sugar increasing for these steroid injections and transient hyperglycemia. For patients with infection risk, immunosuppression or poor wound healing can occur. For patients with severe iodinated contrast allergy, do not reflexively substitute gadolinium for spine procedures. It's really important to note that. Now, let's review a recently done study comparing dexamethasone, methylprednisolone, betamethasone for lumbar transforaminal epidural steroid injections. This is a type of study we really need to see the retrospective evaluation of effectiveness and safety of these steroids. So basically, the study found, I'll have the reference in the show notes, non-particulate steroids, specifically dexamethasone, had comparable, even superior clinical outcomes compared to particulate steroids. This challenges the thinking that particulate steroids always provide longer or better pain relief. Second, they need to look at outcomes like repeat injection need, progression to surgery. There is no clear superiority of particulate steroids like methylprednisolone or betamethasone. And thirdly, safety-wise, non-particulates carry a significant safer profile. Remember, the steroids that are particulate can aggregate embolic risk. Non-particulates do not form emboli, lower the risk of catastrophic neurologic complications. And another testable concept, there is increasing evidence that efficacy differences between steroid types are smaller than we once thought, especially when proper technique and targeting are used. So I hope this helps you out for the boards. This is a real important topic that will probably be tested, but will definitely show up in your clinical practice if you're doing epidural steroid injections. If you're looking to get board prep, go to NRAP Pain or just type in PainExam.com and you'll get our question bank, the virtual pain fellowship, which includes regional anesthesia, ultrasound-guided interventional pain course, as well as the regenerative medicine course. You could go to one of our courses in New York and elsewhere. Hope to see you guys. Just go to nrappain.org and please share the podcast. If you're happy with the podcast, please rate it. And thank you for listening.
Dr. Rosenblum is here solely to educate, and you are solely responsible for all your decisions and actions in response to any information contained herein. These podcasts are not intended as a substitute for the medical advice of a physician to a particular patient or specific ailment. You should regularly consult a physician in matters relating to yours or another's health. You understand that this podcast is not intended as a substitute for consultation with a licensed medical professional. Copyright 2017, David Rosenblum, all rights reserved. No part of this publication may be reproduced, stored in a retrieval system, or transmitted in any form or by any means, electronic, mechanical, recording, or otherwise, without the prior written permission of the author.